So like Jim said, we'll be talking today about emotional and psychological sequelae following COVID-19 illness. And just to preface this, that obviously everything is quite new. We did a pretty extensive search, but there's still a lot of unknowns. So we're just going to share what we found and then offer some management tips. Next slide. So what we know is long haul COVID or long COVID so far has been shown to be the ongoing effects that can be fluctuating with multi-systemic symptoms. You may hear in like lay people referring to long haul COVID or long COVID. So far in the literature, it's recommended to say ongoing COVID-19 or living with COVID-19, since, as Jim said, we don't yet have diagnostic criteria. Through our research, we found that there are multiple surveys of patients worldwide, and so it really varies, but there are about 10 to 80% of patients who experience symptoms for longer than 4 to 8 weeks. Next slide. Some of the effects that Dr. Lee and I have been seeing, and many of you may as well, are ongoing fatigue, anxiety, and interestingly, there's been a focus on new onset social anxiety, low mood, cognitive problems, or patients might describe it as brain fog. And we are seeing patients that actually would meet criteria for PTSD. And just a reminder that the 4 domains for PTSD are hyperarousal, avoidance, negative cognitions or mood, and re-experiencing. Next slide. Some of the causes, there's a few different hypotheses. One is we know there's a well-established relationship between inflammation and patients having affective symptoms. There's also pretty robust evidence about regarding the olfactory nerve and depression. So patients that have damage or shrinking of the olfactory nerve are more likely to experience depressive symptoms. Of course, there are multiple environmental and societal factors that we could talk for hours about. Some of the patients we've seen note feeling stigmatized by family or friends or the community if they've had the infection. And then patients who had pre-existing depression or anxiety have noticed an exacerbation of symptoms as well. Next slide. So for management, again, there's really not strict protocols yet. Dr. Lee and I discussed this at length and with some colleagues, and we would recommend that if you are seeing a patient and they meet criteria for major depressive disorder or a generalized anxiety disorder, to treat them as usual, as you would feel comfortable. A lot of patients with fatigue or sleep complaints, we would strongly recommend trying sleep hygiene first. We know this is difficult and that patients often request medication right off the bat, but really COVID has disrupted people's sleep cycles, and it can be helpful just to get back into a regular routine. If they have a pre-existing psychiatric disorder, or you suspect this is heading more towards a PTSD diagnosis, we recommend referring just because it can usually require a more multidisciplinary approach, including psychotherapy. And just a reminder to check people's medications list, since they may have been started on new medications. And we know that steroids and different antihypertensives and pain medications can worsen depressive symptoms. And please, please, please screen everyone you see. I put substance use disorder, but it really is just heavier substance use. We are seeing people drinking more alcohol or smoking more tobacco or cannabis. And we know that quick question, your NIDA swing question, how many drinks did you have in the last week, followed by a quick open 2-minute conversation can be very effective for patients and help protect them from the effects of heavier drinking. Okay, I'll let you take it, Dr. Lee.
I have to remember to unmute myself. I always forget that. Good morning, everyone. Basically, we want to talk a little bit about how many people live with the psychological and physical effects of long ongoing COVID. In an Italian study, about 87% experienced at least one symptom after COVID onset 60 days later. Of that cohort, 55 had at least 3 symptoms, being fatigue, that was 53%, problems breathing, 43%, joint pain, 27%, and chest pain. And 40% reported a reduced quality of life. As a result of some of these studies, they found that at least 45% of discharged people are going to require some ongoing support, and that's medical support and psychiatric and psycho-rehabilitation support. Of those folks who were not hospitalized, they had symptoms that lasted about 4 weeks or more after onset of COVID, and those who were actually hospitalized with more severe symptoms had symptoms at least 8 or more weeks after discharge. Those people who were admitted, and I think some of my screen you can't see, those people who were admitted and those who were not reported that they had persistent chronic problems, including fatigue, myalgia, anxiety, and varying degrees of intensity, to varying degrees of intensity. These ongoing physical and mental health sequelae really have, like the respiratory problems, anxiety, depression, adjustment disorder, PTSD, and other things are going to require some significant help and social care after the pandemic subsides. So when we talk about the experience of long COVID, really it's very hard because there's no set pattern. It's not always a linear disease. So physicians and medical healthcare professionals and even psychologists have challenges kind of really getting to the bottom of things with the patients who come in having these experiences. It can also be cyclical, where these symptoms can kind of ebb and flow, and people can feel like they're getting better and feeling good, and then all of a sudden have a downturn and then become pretty depressed as a result, feeling like it's never going to go away. The symptom journey is really challenging for these individuals because it's comprised of a wide range of lots of interconnected symptoms, and people have a tendency to look up things online, get very hypersensitive about what's going on with them, and sometimes even thinking that these symptoms are something that is an even more significant, impactful, and even lethal disease. And also these symptoms might not be severe one at a time individually, but collectively they leave people very severely debilitated in the long run. As a result, people tend to turn to things like social media for peer support and folks kind of checking in. It's like, I experienced this, do you experience this? And not having a lot of guidance around it. They also have the experience of feeling doubted about what's going on with them in their journey because there's no real pattern of symptoms that healthcare providers and others can kind of really hone in on. Consumers end up feeling like their experiences aren't believed. People don't really kind of get them, and they just don't even understand what the point is of going to their providers and to psychologists if nobody really gets what's going on with them. So they start to feel isolated, they feel alone when they're coping with the disease, and that causes them to feel like more depressed in their journey. I'm not going to go into a whole bunch of detail on each one of these approaches because we were kind of limited in time, but I did want to mention some of the psychotherapeutic approaches that we do use when we see people who have ongoing COVID-19. When people present with depressive symptoms, we often use CBT therapy for depression. We also use CBT therapy for anxiety too, for the anxiety symptoms that they might have. And this is basically just working on dealing with unhelpful thoughts and behaviors that are present when it comes to feeling like their experience is never going to end, feeling like they just don't really connect with others, and they don't want to connect with others now because they don't want to, continue this cycle, this path. Another approach that we use is called acceptance and commitment therapy, and that really is about, it's a blend of mindfulness, and accepting and committing to what's happened to them. So really kind of thinking about things in a different way, but adding, some hopeful and being in the moment types of experiences. We also use behavioral activation. We call that BA. And with behavioral activation, what we're really doing is when you're experiencing a negative type of experience, we start to kind of think about things in a negative way. And so what happens is we kind of fall into this downward spiral. We become more depressed. We don't have a lot of positive reinforcement in our environment. And then we start to sometimes use some pretty, as Dr. Cook mentioned, some pretty unhelpful coping mechanisms and strategies to deal with those things, such as drinking or sleeping all day, to kind of avoid all the negative and little positive reinforcement that you get. So what we do with behavioral activation is we kind of use small steps to have more positive experiences in people's day. And sometimes it's just as simple, if somebody has severe depression, it's as simple as, okay, let's think about brushing our teeth this week once a day, or getting out into the air, taking a walk once a day this week, and building upon those. As they have more positive experiences, then that opens up the journey and the opportunity for more experiences in the environment, and decreases those negative reinforcement types of coping strategies and skills that they use. Again, for anxiety, we also use cognitive behavioral therapy to kind of address those unhelpful thinking patterns that have to do with anxiety. We also use systematic desensitization and prolonged exposure therapy. These are both kinds of strategies that we use where we're kind of addressing the scenario. It could be in vivo or it could be imaginal. And we're kind of talking about the situation, what is causing you to be anxious, and then also introducing strategies that like mindfulness and relaxation therapy to get the person to become a little bit more calm when they're thinking about these situations and talking about these situations, because you can't be anxious and calm at the same time. So as people start to talk about these things and we introduce some kind of in vivo scenarios where they're in a safe environment to kind of approximate some of the things that they're anxious about, maybe it's going into the office. It might not be in a setting where there's a lot of COVID patients or COVID positive patients, but just being in the office in general, or going to someone's office and then talking about how to be calm. And we do this by talking about what we call subjective units of distress. So if somebody goes into a stress-producing environment and they say their stress is at a 10, we work to get them down to a 3 or a 2 if possible before going on to the next in vivo scenario or imaginal scenario. When we talk about the PTSD types of experiences, we use trauma-focused therapies. And trauma-focused therapies, there are 3 types. One I already talked about a little bit, which was a positive exposure, prolonged exposure therapy. Others are cognitive processing therapy. We go and we talk about the experience and we process it in a way to where that stress evoking situation, we talk about it, we describe it pretty much over and over again to where it kind of gets habituated and not so stress evoking. We can think about it in a different way. Common elements treatment approaches is the same type. It's also a trauma-focused therapy, but we make this, it's kind of modified. You can talk about that stress-evoking experience and you modify the treatment strategies that you would use to address that anxiety or that depression or the PTSD in general, if you're hyper vigilant in situations like that. So we modify it to address those specific symptoms, why it's called the common elements. And finally, we use mindfulness-based cognitive therapy. And the mindfulness-based cognitive therapy is really tackling those unhelpful thoughts and behaviors and using mindfulness approaches. And that could be meditation, relaxation, and things like focused breathing, which some of you probably have no doubt heard before. And this is generally how we approach folks who have had challenges with long ongoing COVID-19 symptoms. That's it. We have some resources as well. Thank you. Any questions really quickly?
Hey, thanks so much, Drs. Lee and Dr. Cook. Really appreciate that. There's some element of prolonged COVID that reminds me of chronic fatigue syndrome. Is that just me, or are there some parallels that are useful? Thanks.
No, I think there's a lot of parallels. And when Dr. Lee and I were reviewing for this, I think the approach and the management eventually, I predict, will turn into a model that's really similar to treating someone with chronic pain or chronic fatigue. They might need more frequent visits that are maybe briefer, but just kind of checking in more, reviewing symptoms, and again, hopefully using more of a behavioral approach rather than piling on a lot of medications. But I'm getting the same feeling as you. Mm-hmm.
All righty, well, thank you so much to our speakers, and thank you to Jim for organizing. And I hope that everyone has a really good week. And we also thank you for Sarah's information.